Good morning, everyone. Whoa. Okay, big room. I think we'll start. I'm just the intro. My name is Lina, and I'm an associate professor at Tulane School of Public Health and Tropical Medicine in the Department of Tropical Medicine. And it is my great pleasure to introduce my very good friend, Dan Bausch, today to deliver the presidential address. So what I'm supposed to do is introduce Dan in as appropriate, but at the same time roasting as possible. So I'll try to live up to some expectations. Dan grew up in Rochester, New York, a city so overcast with gray and dreary weather that he claims he never saw the sun until he left for university, where he earned his bachelor's degree in psychology from Northwestern University in Chicago in 1983, with aspirations to be a neurosurgeon. Dan. So, luckily for the world of infectious diseases, he changed his focus during medical school, staying in Chicago to attend Loyola's strict school of medicine. So with all this talk about Chicago, I'd like to remind everyone that next year the ASTMH meeting will be in Chicago. The society is arranged for all-you-can-eat deep dish pizza for everyone who attends, and all you have to do is send the bill to Dan. So, good. So, after residency, I have a paucity of photos of Dan, and I have an explanation for this soon. So I thought it might be good to actually try to give you an idea of the places where Dan has worked, not just flown to and had meetings, which would be nearly every country, I think, on this map, but areas, at least to my knowledge, and to the knowledge of his CV, he's worked in. And so just to give you an idea, I'm going to kind of move through this as we move through the timeline here. So next slide. He has been in North America at this point. So after residency in internal medicine at Boston University, Dan did an infectious disease fellowship at Tulane University. Roll wave. It was at Tulane in New Orleans that Dan discovered that winters don't have to be so bad and brutally cold, that tropical diseases actually happen in the US, and that a late carnival or Mardi Gras season or a rain-free jazz fest is about one of the best things in the world. So during Dan's fellowship, he also completed a master's of public health and tropical medicine, and Barney Klein was Dan's mentor. And through Barney, Dan made his first, and maybe I think his last foray into research on helminths, studying schistosomiasis in a very, very rural community in Cameroon. So after his infectious disease training at Tulane, Dan served as project director of community health and training with the International Medical Relief Fund in El Salvador. During this time, civil unrest erupted between Zapatista militias and the Mexican government. So Dan took a detour to volunteer in Chiapas, Mexico, with Doctors for Global Health. It was there that he met Frédéric Jacquerio, a Swiss infectious disease specialist who was providing medical care to indigenous Mayan populations. So I asked Frédéric to send me some photos of their time in Chiapas for this talk. Instead, she sent me this. So, well, Dan is at ASTMH, embarking and then about to embark on a weeks-long work trip that will take him around the world. Frédéric and the kids are packing up the house. And so somewhere in those boxes are breathtaking photos of Dan and Frédéric falling in love in Chiapas. Trust me on this. So Dan, Frédéric wanted me to let you know that she's got the packing covered, that she appreciates the opportunity to do this solo, and she'll remember this. So Frederique is wonderfully accomplished in her own right. Currently, she's the clinical chief of international and humanitarian medicine at the University Hospital of Geneva. She's deployed to several Ebola outbreaks, both in clinical care and training. And she also oversees preparedness in clinical care at her hospital for the monkeypox pandemic and other epidemic threats. Over the last 20 years, Dan and Frederique have managed to balance their demanding careers and raise two amazing, remarkable kids, all at the same time. So after meeting Dan in Chiapas, Dan joined the US, so after meeting Frederique in Chiapas, sorry I made this about Frederique. So Dan joined the US CDC as a medical officer in the Special Pathogens Branch. It was here that he honed his expertise in viral hemorrhagic fevers. Dan directed many response and surveillance activities for several outbreaks. And these are some of them. I had to throw in some pictures here of Dan with a little more hair, and maybe a few other people that some of you may recognize. But these included outbreaks on Ebola in Uganda, in Gabon, in the Republic of the Congo, bat collections for Marburg in the Democratic Republic of the Congo, rodent studies on hantaviruses in Bolivia, and this is where the photo came from, and SARS coronavirus in Vietnam. So he also started to put some roots down in West Africa, serving as a consultant for UN peacekeeping missions in Sierra Leone and Liberia, and leading an expansive research project on Lassa fever in Guinea in collaboration with Tulane. These studies focused on the clinical characterization, seroepidemiology, and rodent ecology, and were really foundational to what the knowledge that we have on Lassa fever today. So recall that Dan is an infectious disease physician, but clearly he wasn't really interested in restricting himself to clinical research. So the CDC's Stuart Nickel recalled of Dan that while he was managing research teams, he was also trapping, freezing, shipping samples to CDC labs in Atlanta for further analysis. He was trying to get solar panels placed on the lab roof to generate more energy. Most clinicians wouldn't be doing that. He was willing to get his hands dirty and do what needed to be done. So peacekeeping deployments came at an end at the end of some brutal civil wars in Sierra Leone and Liberia that had destabilized the area of West Africa, known as the Mano River Union. So Dan was transitioning from the CDC to a full-time faculty position at Tulane in the Department of Tropical Medicine. It was at this time that tragedy struck. Dan's collaborator in Sierra Leone, Dr. Anuru Conte, contracted Lassa fever and died. So Dr. Conte's death galvanized national and international partners, some of which are here today. Ministries of health from the Mano River Union countries, WHO, Tulane, the UN, the Office of Foreign Disaster Assistance, USAMRID, and others came together to form the Mano River Union Lassa fever network. The goal of this network was to assist in development and of national and regional prevention and control strategies for Lassa fever. If you study viral hemorrhagic fevers, you'll learn that it's really difficult to find them when you really want to. And Lassa fever is one of the few diseases that is endemic enough in West Africa that you can actually set up some predictable and robust studies. And so this is one of the reasons why Lassa fever was targeted. So a lot of the efforts were put into enhancement of laboratory diagnostic capacity, training in laboratory diagnosis, clinical management, infection, and environmental control. So the Lassa fever, the Mano River Union Lassa fever network was unprecedented, and it was ambitious. It moved the nexus of research into the heart of Lassa fever territory, with the ministries of health in Sierra Leone, Guinea, and Liberia at the helm. And this integrated international global health It integrated the global health security agenda with local priorities and strategy. Kenema, Sierra Leone was the first research hub to go into effect, and Dan served as the senior medical or technical advisor. Dan tapped a young Sierra Leonean physician named Humar Khan to oversee day-to-day operations of the site. And he brought several other promising young Sierra Leoneans to lead the team. So Dan made the official move to Tulane in 2003. I came along the next year, and this is how I remember Dan looked. He brought along the Mano River Union Lassa Fever Network with him to Tulane. So I came to do my MSPH in tropical medicine. I'd spent several years after undergrad on my own studying about health and how rooted it is and fundamental to human rights, but also viral hemorrhagic fevers. And so I felt like meeting Dan was like destiny. So I started volunteering in his research group, essentially spending hours in his office filing documents, but really just bugging him with a million questions about different outbreaks, the people he worked with, the research he had done. Dan was always willing to share his world with anyone who was interested. He spent hours each week with a steady stream of students coming to him with the existential graduate student question of what should I do with my life? And he listened to them, and he advised them thoughtfully, sincerely, and honestly. I remember he told me that I should probably not seriously think about medical school after hearing what my undergrad GPA was. So I stayed with Dan at Tulane for my PhD and continued to work on Lassa fever. So in 2010, a new opportunity opened up for Dan to head the Virology and Emerging Infectious Disease Department at the U.S. Navy Medical Research Unit, number 6, in Lima, Peru. So Dan, Frederic, and the kids packed a few things and headed down to Lima. While leadership roles were not new to Dan, running this large department with a broad mandate for research training and system strengthening in partnership with several South American countries was broadened your horizons, I think. And I think you did it amazingly well. So Dan managed to get back in the field, all while leading this department with a project looking at the social and ecological impact of the construction of the Pan-American Highway. And like the previous students that had benefited from his mentoring at Tulane, he had a slew of junior scientists who found a supportive mentor, and many of them have gone on to advanced studies and progressed in their careers. In 2004, Dan found himself back in the Mano River Union, leading clinical teams in Guinea and Sierra Leone and Liberia for the Ebola outbreak. By then, I was doing my postdoc, continuing work in Lassa fever research in Sierra Leone, and had been thrown into an epidemic response that I had no idea how to control. Luckily, Dan arrived in early July, and I will never forget one of his first comments to me, and this, keep in mind, is a seasoned Ebola responder, that he'd never seen so few responders to such a big, big outbreak. I think many of us know the tragedy that unfolded in Kenema and throughout the region. What happened there hit hard for Dan. We lost a lot of our colleagues that we'd worked with for years, including Humar Khan. The aftermath of that was a time of reflection on what we should have done and what we must do better in the future. And no one was more critical than Dan. So for those of you who are familiar with Dan, you know that he's very articulate, succinct, and informed. His ability to communicate has made him a trusted source for journalists and has allowed him to advocate in ways that most others can't. Initially, I was really reluctant to talk to journalists, and Dan spoke to me and said that if I don't speak the truth, others with limited or no on-the-ground perspective will fill in the gap. So effective communication and advocacy is Dan's superpower. He's long been an advocate for improved clinical health, clinical care. This is a paper that he published all the way back in 2007. But after the Ebola outbreak, it was a time to roll out the advocacy, to shift what we had been doing in the past. In the wake of the tragedy in Kenema, Dan became fervent about improved care, not just in people experiencing Ebola, but survivors. A focus on long-term consequences of Ebola infection and the need to partner with communities for response. And also the need for broad approaches to preventing epidemics by improving health systems and effectively controlling endemic disease. Leaving Lima, so this is, I think, probably too long coming, but I think a really important piece written by a group of very experienced Ebola clinicians, basically shifting the paradigm where no longer can we tolerate standards for low resource settings and high resource settings. The standard should be one. And I think that this is representative of the kind of work and that Dan has done throughout his career. So leaving Lima to focus completely on Ebola response in 2005, Dan spent 2 years at WHO as a technical lead for the epidemic clinical team before taking a position as director of the UK Public Health Rapid Support Team. RST's mandate was ambitious, once again, with Dan at the lead: epidemic response, capacity building, and research, all at the same time. The team was made up of experienced practitioners from Public Health England, now the UK National Institute for Health Protection, and applied researchers from London School of Tropical Medicine and Hygiene. Dan and his team supported response to the mudslide in Sierra Leone, Lassa fever epidemics in Nigeria, plague in Madagascar, and many, many others. RST continues to support capacity building initiatives with the African CDC and ministries of health globally. And in 2021, after 4 years of commuting back and forth from Geneva to London, Dan took a position at FIND, directing initiatives in emerging threats and global security. If you've caught some of his talks from the conference, you've heard a lot of the work that he's been doing with FIND. And so that's kind of summing up his career. For me, I think there are two things that stand out with Dan. The first is for him to be able to wrap his brain around the most technical aspects of science, all the while understanding how technology fits into the broader picture of both implementation and policy, with humans always the focus. Dan uses his technical expertise and on-the-ground experience to support a fundamental tenet that health is a human right, even in the midst of a health emergency. He's been a champion of locally led epidemic response, holistic and horizontal approaches to preparedness and response, and integrating transdisciplinary solutions that are community-centered and rights-based. The second thing that Dan is deeply committed to is mentoring, to bring along junior researchers, students, and trainees, and open up his networks, making them ready to assume leadership positions. And I have greatly benefited from this mentoring. The flip side is that Dan is also constantly evaluating himself and seeking out mentors to guide him. He's a person who's always assessing how he can do better, how the system can change for the better, and how concepts can be challenged to improve equity for all. He continues to seek out mentors to advise him, and I think this is one of the most admirable qualities, I can't even say the word, admirable qualities he has. So, now a little bit of Dan the man. So, I think the relationship between a doctoral student and their advisor is such a unique relationship. It can significantly impact your mental health, set a pathway for success in your career. And if you're lucky, evolve into one of mutual respect and collaboration. Rarely do you get to develop a very good friendship. And I think, so Dan and I have got 18 years under our belt now. And despite my terrible ability to show it, his friendship is one of the most important things in my life. So for those of you lucky to know Dan personally, you'll know what a loyal, supportive person he is. Despite his busy schedule, you know he always has your back. He's great with birthdays, great conversation with sipping some high-end bougie tequila. He's great to watch the World Cup with, and I'm so relieved that he's finally picked a team in the English Premier League, and over the moon that it is Liverpool Football Club. You'll never walk alone. It's fair to say that Dan's most important role, though, has been as a father. And I suspect no one is more surprised about this than Dan. His kids, Nelson and Margot, are much older than they appear here, but those photos are also packed in the boxes right now. They're dynamic, engaged, and know that they are loved by their parents. So last, I'll just leave a few comments on Dan's commitment to the society. Dan's been a member for decades. In 1998, he became a member of the scientific committee and has served as a counselor, from 2011 to 2014. He became the scientific program chair in 2015, and he's worked very closely with ASTMH, values them and praises them constantly, and the important work that they do. During his time, the society has expanded its scope, expanded its membership to be much more inclusive, and engaged in international advocacy at a much greater rate. So he's just finishing up his first year as president of society, and it looks like we're up for a round 2 as well. So I'm very excited to see what the next year has to come. Thanks, everyone.
Thank you, Lina. Thank you, Lina.
It's not tequila.
Unfortunately, I could use a bit right now, but no. Thank you very much. It was, I expected to laugh a little bit with what you would say, but I hadn't anticipated that we would have to hold back tears. But thank you for bringing up some of our colleagues in Sierra Leone and elsewhere. Regarding Frederic, can I just say that I did suggest that we put off the move until later in November, but and that patience is not always her best quality, and so she elected to go ahead. And then lastly, before I make more substantive comments, it's not a great year for Liverpool so far, and I don't know how you beat City and then lose to Nottingham Forest, but anyway. So I want to talk today about the nexus of our field of tropical medicine and human rights. As Lina explained, I've been lucky to have very diverse experiences. She embellished a little bit, I think, here and there, but nevertheless, I have had the opportunity to work in a lot of different settings with a lot of great people and a lot of great mentors, many, many more than I could actually thank. These include, as Lina pointed out, setting up Lassa fever programs in West Africa, running an Ebola treatment ward years ago when I was doing more clinical work in Uganda, conducting contact tracing for SARS-CoV-1 in Vietnam before SARS-CoV-2 came and took over our lives. She mentioned trapping bats in the Congo. I didn't know anything about this, but I had other colleagues who were skilled in getting me into some of this disease ecology work. Incidentally, that was where my family gave up trying to understand what I do for a living. The idea of, they had more of a sort of a white coat taking your blood pressure doctor than a trapping bats in the Congo doctor. But my mom was almost embarrassed. She's like, my son's a doctor, but we don't like to talk about it. And But my first exposure really in some of the human rights challenges, which are quite evident here, came when I was in university in Chicago at Loyola Stritch School of Medicine. Really not really sure how this became important to me, but I ended up being the president of a small, just the university, the medical school chapter of Amnesty International. This was in the 80s, and at the time, many of you in the room are old enough to remember that the wars were raging in Central America and in El Salvador and Guatemala and Nicaragua for different reasons. And there were a lot of people, of course, naturally fleeing those tragedies and coming to the United States. Some of them had their papers, so they were documented. Many were not documented. And there was something called the sanctuary movement to basically give shelter to people needing shelter from what was happening. And I became quite involved in that over the years as a medical student. And it kind of made me aware and woke me up to those things that were happening in Central America. And that led, when I moved on to my residency in conjunction with various NGOs that I was engaged with, that led to starting to spend time in El Salvador, initially during the Civil War, later on after the Civil War. So when I would have a 2-week break or something go on, I would go to El Salvador and work with colleagues there. Those were projects that were human rights focused. We weren't funneling guns to rebels or anything, but we were defending communities that were having their human rights trampled by a totalitarian government, and a place where just the idea that communities would band together and that they would form healthcare systems together, that they would have health promoters that would basically tried to take care of a community, was considered leftist and subversive, and really leftist and subversive enough that helicopters would come and bomb those towns and villages, and that death squads would come and take you away in the night just because you felt that that was the right thing to do. That was, of course, a very moving moment for me to be experiencing this. We were protected as North Americans. It wasn't good policy, actually, to be violent towards North Americans, because a lot of the money was coming from North America to promote the government there at that time. So it didn't really matter too much. No one was going to worry too much here and there about a missing Salvadoran, but didn't want anybody who might be writing their senator and saying what's going on. So it was clear that when we thought about health, just a clear definition of health as something, the absence of disease, was really not sufficient, and that this was a complicated social and political, the social and political roots of health were very evident in that sort of setting. During my time in El Salvador, I was there when cholera initially reintroduced into Peru in 1991, then snuck up the coast and basically crashed on the shores of El Salvador. And so we started to see hundreds of patients a day coming in to cholera. That was incidentally my first experience in isolation and treatment wards. Later on, I would be in those for Ebola and Marburg and other things. They're a little bit different, but my first experience with that. And again, the connection there between kind of the social political environment, but now adding in that the tropical diseases are part of this as well. And so starting to see how this came together. Not surprisingly, a few years later, and my first foray into contributing to the scientific program at ASTMH was a symposium called Social and Political Issues in Tropical Medicine that we did for a couple years that tried to get to the roots of some of these things. And of course, the science is important, but thinking about those roots that are equally important. Not by design, but my time in El Salvador began a steady continuum of engagement in war-torn areas, or at least areas with political unrest, and Lina detailed some of those. So, that was cholera in El Salvador during a civil war there, Lassa fever in Sierra Leone during a civil war, Marburg hemorrhagic fever in the Democratic Republic of the Congo. I remember WHO needing to negotiate with the rebels to allow the plane to land without shooting it down so that we could go investigate there when I was with CDC. Ebola in Uganda, northern Uganda at the time, when the Lord's Resistance Army was quite active, and really terrible things happening there. We had to have escorts to do the contact tracing in the field. So you couldn't, of course, ignore all this, that these beleaguered populations and systems, healthcare systems that were decimated by what was going on politically, and really, existential crises seemed to become the norm to me. Everywhere I would go, there was an existential crisis. I was always viewing it from the outside, which was sad but tolerable. As an aside, And many of the people from Tulane and my friends and colleagues from New Orleans will remember, our own existential crisis when Hurricane Katrina hit in 2005. It was a different thing when the existential crisis was your town. And, sounds strange to think about this now, but I remember conversations and, is Tulane as a university, is New Orleans as a city going to continue to exist, and for like a year those conversations went on, a tough time where we had our own existential crisis that did not seem like the norm. This string of coming back to the infectious diseases and the outbreaks and those things, of course, I didn't know, and I don't think any of us were talking about the term then, but this was a clear evidence of kind of One Health and how we're linked to, the humans are linked, because these are all zoonotic diseases that come from animal sources. So you don't have to be around such settings very long to understand that the major challenges extend far beyond just your particular and often singular disease focus. How to talk to a man, I remember vividly, how do you talk to someone, a man who had just very recently had his limb cut off by a child soldier in Sierra Leone, about he should be worried about a rodent-borne virus called Lassa? Or how to talk to a woman in North Kivu in Democratic Republic of the Congo about something called Ebola that she needs to be worried about because this disease could be difficult. And she says, well, I had 2 kids who died of malaria in the last few years. No one was here asking questions about that. No one was thinking too much about that. And now you want me to worry about a virus or a disease that I've never heard of, and in many cases think maybe you brought it, or maybe you have your own reasons to be warning me about it. And so clearly, we had to think more broadly than just our particular disease. That was something I think no, you're not seeing the slides. I'm seeing the slides. If our AV team can, no, I'm seeing the slides, but you're not. I don't. Anyway, there. The story and some of the antecedents of Ebola were, so I would recommend this book, Fevers, Feuds, and Diamonds, by, of course, one of the icons, and the sad loss of Paul Farmer, who really went and was so good at going into, these issues. And so, I'll put this, boil this down to the rest of my talk. It's about human rights. And we actually just had a good conversation a few minutes ago in the session before this when somebody asked, how do we build the surveillance systems in the right way? And the surveillance systems need to, not only because ethically it's the right thing to do, but strategically it's the right thing to do, to have a much broader approach that monkeypox, for example, is not just important because it's come to Europe or the Americas. Monkeypox is important in Central Africa and West Africa where it's endemic. So let's talk about human rights. What exactly are human rights? The idea of tropical medicine and human rights being intertwined is not exactly a new thing. Actually, if you look back at the last 4 or 5 presidential addresses, human rights were mentioned. And in fact, most of those presidential addresses were more focused on activism and addressing kind of the broader antecedents and determinants of health rather than specific topics on a science or a disease. So human rights, what are they? There are numerous documents and accords that seek to define them. The Universal Declaration of Human Rights was drafted in 1948 on a committee chaired by Eleanor Roosevelt, the wife of then Franklin Delano Roosevelt, the President of the United States. Was adopted by the United Nations General Assembly. In the 30 articles, the document enshrines the rights and freedoms of all humans, affirming their universal character as inherent, inalienable, and applicable to all. Someone must be paying attention because it turns out that the Universal Declaration of Human Rights is the most translated document in the world into over 500 languages. With specific regard to health, Article 25 stipulates that everyone has the right to a standard of living adequate for the health and well-being of himself and his family, including food, clothing, housing, and medical care, and necessary social services. The UN further defined the right to health in Article 12 of the 1966 International Covenant on Economic, Social, and Cultural Rights, recognizing the right of everyone to the enjoyment of the highest attainable standard of physical and mental health. Meanwhile, the preamble of the 1946 WHO Constitution, recognizing that this was a new institution at that time, defines health broadly as a state of complete physical, mental, and social well-being, and not merely the absence of disease or infirmity, and enumerates some principles of this right as healthy child development, equitable dissemination of medical knowledge and its benefits, and government-provided social measures to ensure adequate health. But of course, these are just documents and covenants. These are the technicalities. I don't actually think that the members of ASTMH, the people in this room, really require much detailed explanation. All you really need to know is to ask yourself, how would I like to be treated? What treatment of me would I claim is unjust? And what care would I need and would like to keep me healthy and to restore my health if I fall sick? I believe that your answers of what constitutes a right to you and to us all as humans will be quite evident. Why are human rights important as a framework for tropical medicine and what we do and to our society? It's not to appear woke or to be on some particular side of a political agenda, but rather because it's critical to our mission. With our scientific contributions, the world has many positive results to note regarding health indicators. Life expectancies are drastically enhanced around much of the globe. Many infectious diseases, such as malaria and some neglected tropical diseases, are under better control or even near elimination. And rates of protein energy malnutrition have dropped, although many of these indicators took a step back during the COVID-19 pandemic. Julie Jacobson's presidential address last year actually went through some of the numbers and some of the progress that we have made. But human rights are the appropriate framework for what we do for tropical medicine, because while the contribution of science to many of these health indicator gains is undeniable, I fear that we are reaching the limits. As a result of our collective efforts in many fields, we now have the right tools: diagnostics, therapeutics, vaccines. You've heard all about that this week and still for another 24 hours. So we have the tools to do the job, but nevertheless it remains undone. We struggle with implementation of our science to ensure impact. The varied uptake of COVID-19 vaccines, so thoroughly addressed in Heidi Larsson's book, Stuck, which I would recommend, a good friend and colleague from the London School, is a great example of the challenge. I can also cite my time at the UK Public Health Rapid Support Team, as mentioned by Lina, where probably half of the things that we were attending to in terms of outbreaks were vaccine preventable. So the solution already existed, it just wasn't getting to the right people. So the technology in and of itself is clearly not enough. Another reason to adopt a human rights framework is because rights are under attack. We tend to take them for granted, but I would venture to say that in recent years there have been some concerns about our rights, that things have slipped when we let our guard down. Controversial computer intelligence consultant Edwin Snowden put it simply, "Your rights matter because you never know when you're going to need them." Furthermore, the data are clear that pandemics and epidemics occurring with increasing frequency further widen inequities and human rights abuses. If we do not address inequities through a commitment to human rights, we will forever be behind. Not only the wrong thing to do ethically, but as I mentioned earlier, strategically, since COVID-19 taught us we are all connected and addressing these everywhere is important. So who ensures human rights? Of course, it's easy to say that something is a right, but that doesn't make it so. Indeed, human rights are frequently trampled or ignored, and then upholding them can seem like a losing battle or a waste of time. And for many human rights, the enforcement mechanisms are few. Furthermore, the framework for human rights itself is far from perfect. The Universal Declaration was created largely by high-income Western countries and is focused on individual as opposed to collective group rights. There are concerns over the overarching reach of the state in assuring human rights, and the language of the document itself is not neutral, referring consistently to he and him. Added to this is the question whether we in the field of tropical medicine, with its background related to colonialism and racism, are we the right people to be the champions of human rights? Nevertheless, where would we be without a framework for human rights? What standards would we use to assess right and wrong on the international stage? What justification to further our trade, to advocate for funding and access? I submit to you that despite its imperfections and shortcomings, the Universal Declaration and standards that have been developed over the last 75 years represent an incredible human achievement, expressing commonalities that we share, and at very least provide a seed which sprouts recognition, if not, and hopefully action, when rights are ignored. As to who upholds human rights, Eleanor Roosevelt asked the same question and answered it thusly. Where, after all, do universal human rights begin? In small places close to home, so close and so small that they cannot be seen on any maps of the world. Yet they are the world of the individual person, the neighborhood he lives in, the school or college he attends, the factory, farm, or office where he works. Such are the places where every man, woman, and child seeks equal justice, equal opportunity, equal dignity without discrimination. Unless these rights have meaning there, they have little meaning anywhere. Without concerned citizen action to uphold them close to home, we shall look in vain for progress in the larger world. Are we looking in vain? When Ms. Roosevelt, what she forgot to mention was that ASTMH is one of those local actors in 1948. I also wanted to see if the ASTMH president in 1948 had mentioned anything about us upholding human rights, and I couldn't find the ASTMH president. I asked Don Burke, he's going to get it to me, but I don't think it was mentioned either. But I submit to you that with regard to health, ASTMH is and must be that local embodiment, that neighborhood that advocates and upholds human rights, giving human rights real-world meaning through our work to make a healthier planet. We, as scientists and healthcare workers, must play a role as the advocates and guardians of the human right to health. Much of this work is direct through the evidence that researchers produce and the care that clinicians and field workers provide. But we must also be the advocate, the reminder, when necessary, the thorn in the side, to politicians and policymakers to uphold this right. If we don't perform that function, who will? Still further, we should consider the advice of former CDC director and public health icon Bill Foege, who encourages scientists and healthcare workers to enter the political realm themselves, to advocate and set policy from within the political systems. Certainly, advocacy for health as a human right must be part of that job, and no group of people is more qualified to perform it than ASTMH members. Why us, you may ask? Why should we be the ambassadors or advocates for human rights? Most of us consider ourselves first and foremost scientists and healthcare workers. Isn't it the politicians' and activists' job to advocate for and ensure human rights? And of course they must. But I can tell you we must also engage. I'll give two reasons. First, despite the troubling lack of trust in our society today, scientists, clinicians, healthcare workers, we still enjoy a privileged vantage point in most societies around the globe. Justly or unjustly, this provides a podium to speak, to raise your voice above the din. Furthermore, because your views and advocacy are evidence-based, you can make a better case that your views are not politically motivated, not expressed because you are on the potential left or right, but because the scientific evidence presents you with a truth that you can share. And I think that podium is extremely important. I was always very proud of being able to say, and thought extremely important to be able to not come from a political perspective. We all have our political affiliations, left or right, but the important thing for me was to be able to say, well, this guy seems like a fairly normal person. He's a university professor. He published papers successful. I published papers in New England Journal and Lancet and Impact Factors and all that. But then when he says that torture is a bad thing, maybe that makes sense. Maybe it's not because he's on one end of the political spectrum. So I think actually you have a particular vantage point that not everyone has. And that doesn't mean it's bad to work for a human rights organization. But of course, if you work for a human rights organization, everyone right away will say, oh, well, that's because you're this leftist, this, or you're right, or whatever. And I think if you're a scientist, you can rise above that. Secondly, and most importantly, Human rights advocacy falls within your job precisely because you are scientists and healthcare workers. And not only scientists, but life scientists. We're not paleontologists, we're not physicists. Our job is not to simply document or explore the physical world. You're in this field for impact, for intervention. You want to change things. You want people to be healthier. And in order to do that, your scientific pursuit, inherent in most of our daily lives, is a noble cause. But your mission is not simply scientific pursuit, but the pursuit of health. For us, science is a step in a process, not the end goal. It's easy to become lost in your expertise. We all do this. The disease that you study, the grant that you write, the paper that you publish, your struggle for tenure and recognition, all important things. But not truly yours, nor our society's goal. Our job's not done, our goal not reached. When the scientific evidence is generated, the manuscript published, ideally in a high-impact journal, unless that evidence, that paper, has impact. And I don't mean the journal, I mean leading to a healthier person, patient, and planet. Don't give in to pessimism or indifference. I realize that some in the audience may feel frustrated, perhaps lamenting the days, if indeed they ever existed, when we and the society could just focus on the science. With challenges seemingly coming from all sides, it's hard to stay optimistic. Nor can I claim any Pollyanna optimism myself. If you're not alarmed by the present state of the world, you're obviously not paying attention. Overwhelmed, we often continue our vertical focus on a particular disease, not wrong, but not wholly sufficient toward our goal of assuring health. No doubt, this is a protection against our feelings of helplessness about the suffering we often witness. We do our best to make amends through a fix to a part of the problem, but we know inside that we're still ignoring the root causes. I like to revert to two famous Pauls for wisdom and stamina. The Apostle Paul said, "I have fought the good fight, I have finished the race, I have kept the faith." A few millennia later, another famous Paul, Paul Farmer, expressed a similar sentiment, albeit in a much different context. We want to be on the winning team, but at the risk of turning our backs on the losers, no, it's not worth it, so we fight the long defeat. I hope we don't have to admit defeat, but I take a certain confidence that feeling, even if I'm pessimistic, that fighting the fight is an extremely important thing to do. And that way, we don't get caught up in saying, is it worth it or not? So that the fight, I think, is an important part of that. It's worth it to make the fight, regardless of what the outcome may be. I'll conclude with expressing my personal, and through the privilege of serving as your president, the Society's commitment to human rights. In the next year, we will revisit the ASTMH strategic plan, something we would be doing anyways, into which I hope to codify human rights and to work with our scientific program chair, Christy Peterson, to enhance human rights frameworks into and integrate human rights frameworks into our scientific program, to ensure that they live beyond any one president's tenure or any one annual meeting. This could include such offerings as a yearly lecture and symposium dedicated to health and human rights and many other things. But of course, we have to do more. That's why I call on ASTMH members to make human rights the underpinning of your daily work. I believe that, recognized or not, human rights are why you choose this field and work so hard, why you are a member of the society and sitting here today. This does not mean that you have to shut down your lab, march into the street, or choose a new career. You don't have to quit your job and join Amnesty International or another human rights-based organization. But I do propose 5 actions to incorporate into your daily work and your daily life. First of all, keep human rights as well as past President Julie Jacobson's 3 C's of compassion, culture, and courage in all you do. Do your science, study your protein conformation, your immune response, see your patient, but keep human rights in mind. Talk about it with colleagues and students. Include a human rights framework to your lectures and writings to keep us from getting lost in the science, the proverbial forest for the trees. Human Rights Day, December 10th every year, can be a rallying point. And I have to say, when I was teaching much more at Tulane, I taught a couple different classes and felt very proud that one of them was emerging viruses, one of them was tropical virology, and the other one was health and human rights. And the class that probably got the most response was the health and human rights one. And not because I have, really a didactic expertise in that, but the purpose for me was just to plant that seed. And I'm looking at a former student and TA who asked me about it last night. I think the seed was planted in her at least, and I think it's important really to try to plant that seed with everybody so that they use that framework, so they think about this. And again, it doesn't mean that you give up being a scientist. These things go together. And what I learned, and Lina talked about, my first job coming out of my training was in El Salvador. And I went there really specifically because I wanted to work in human rights. It didn't work out for me in some ways in terms of being the right fit for me. And I realized that didn't mean that I, being dedicated to human rights doesn't mean that that's all you have to do every day, right? You don't have to make that your full-time job, but you can integrate that into whatever you do. So think about how to integrate. My second point, be a witness and share your testimony. Virtually all of you live or work in countries or settings, including both low and middle income countries, but also in high income countries, because this is just not only a low and middle income country thing, where the right to health is often not respected or ensured. You see it regularly, even if perhaps now it's become so routine that it ceases to shock. You are a witness to things that few politicians and policymakers can see. Your testimony expressed in the right way can bring problems to life, citing health problems and focusing politicians and policymakers in a way that can't happen through reading some document or about an event secondhand. Thirdly, advocate for universal health coverage and access to health services. No matter what your field or your discipline in the health sciences, it cannot have impact, and I would maintain that it's largely purposeless unless a person's right to health care is assured, allowing them to access the benefits of your scientific work and progress. Fourthly, think about the value chain. What will it take to maximize the impact of your work? No one person can do it all, but how can you link and support other collaborators and institutions, scientists and non-scientists, to assure that we address all the nodes along the value chain that result in maximum impact on health? And lastly, number 5, vote and advocate for human rights, both on the national and international stage, but also within ASTMH. And I'll make the side point that usually when we put out those calls for action in ASTMH, the response is not very good. So let's be better at that, people. Yes, I'm talking to you. And it just takes a minute, and it makes a difference. So, in conclusion, your means, the thing you do every day, may be research or clinical work, but your end is improved health in all its senses, and a fundamental respect and advocacy for human rights is an essential tool to meet that goal. Thank you very much. Thanks, Lina. Thank you. Yeah. Huh? I think we're good. Yeah, I think we're done. Thank you.